Thank you, ma'am. Thank you for having me. I'm going to start my video now.
Combined trabeculotomy and trabeculectomy, tips and tricks. Combined trabeculotomy with trabeculectomy is the surgical technique of choice in primary congenital glaucomas in Indian pediatric population, owing to more severe disease compared to Western pediatric population. It can also be undertaken in cases where previous angle surgeries have failed and in hazy corneas. It has shown to have maximum success rate when performed less than 3 years of age. The rationale behind doing this combined procedure is to obtain access to dual outflow, namely through the Schlemm's canal and the trabeculectomy fistula. Particular challenges of this surgery include small palpebral fissure, less rigid and thinner sclera, and different than expected location of landmarks in ophthalmic eyes. Surgical technique. Corneal traction suture is taken using 6-0 vicryl suture. Conjunctival dissection can either be limbal-based or fornix-based, like in this video. Limited wet bipolar cautery can be done at this point if required. Care must be taken not to over-cauterize the episcleral tissue owing to thin sclera due to ophthalmos. Merocel sponges soaked in 0.2 mg per ml of mitomycin C is applied for 2 minutes, sparing contact of the edges of the conjunctiva with mitomycin C, and then washed well with copious saline irrigation. A 4 by 4 mm triangular partial thickness scleral flap is then made using a 15 number blade or a crescent knife. A rectangular flap can also be fashioned. Ensure at least 50% thickness of the scleral flap for adequate coverage of the sclerostomy hole after the trabeculectomy. Also, with a very thin or a thick flap, limbal landmarks may be missed. Finding the Schlemm's canal is an important step in trabeculotomy surgery. First clue. Presence of a small scleral vein entering the Schlemm's canal is an important sign for its location, as these veins drain the Schlemm's canal. Second clue is the junction of the white and the blue zones. It's said, where white meets blue, Schlemm waits for you. Third clue, look for a slight depression at the junction of the blue and white zones, which corresponds to the location of the Schlemm's canal. Once the landmarks are identified, a radial incision is carried out very gently and slowly with careful deeper cuts until a gentle ooze of aqueous is noted. In case of doubt, a 6-0 nylon suture can be used to facilitate the identification of Schlemm's canal by an easy cannulation of the suture without resistance. The location of the incision is very important, as a slight posterior incision may lead us in the supraciliary space. After locating the Schlemm's canal, a Harm's trabeculotome is inserted into the Schlemm's canal and should pass through without any resistance. It is then rotated inside and upward towards the cornea. Care is taken to avoid damage to the cornea. Same procedure is repeated on the other side. One must not rotate the trabeculotome in the plane of the iris, as the base of the iris may be at the level of the Schlemm's canal. A slight hyphema is normal during this maneuver. This way, trabeculotomy is completed over 4 to 5 clock hours. Now we turn our attention to completing the trabeculectomy. The anterior chamber is entered with a 15-degree sideport blade through a separate opening more anteriorly. Sclerostomy is done using a Kelly sponge followed by an iridectomy. The scleral flap is then closed using 10-0 nylon sutures and knots are buried. Releasable sutures can be used as well, which will be the surgeon's call depending upon the case and his clinical decision. The overlying conjunctiva is then closed using 9-0 vicryl suture, ensuring a watertight limbal closure. At the end of the surgery, make sure you check for any blood leaks using fluorescein dye under red-free light. Subconjunctival injection of antibiotic and steroids is given at last. Post-operative follow-up is extremely critical. After the initial post-operative period, patient is followed 6 weekly and examination under anesthesia may be needed till the child is old enough for slit lamp examination. During the follow-up examination should include applanation tonometry, axial length, corneal diameter, gonioscopy, fundoscopy, retinoscopy, and slit lamp examination for corneal clarity. Thank you.
Thank you, Dr. Sahebaan, for such a nice video presentation.
Thank you.
I call Dr. Is Dr. Sirisha madam there?
No, ma'am, I think she's not.
She has not joined. No? Dr. Ganesh Raman is there? No. I would like to have Ganesh there. Welcome, Ganesh.
Yeah.
Dr. Ganesh and Dr. Ankur, please give your expert opinions regarding rabbit trap.
Yeah, thank you very much. I noticed that you used 3 types of sutures. Is it possible to reduce the number of sutures? You had a 60 for the the number of
corneal traction.
Yes. Corneal traction, and then you had a 90 for the congenital closure, and then a 80 for the, or 10-0 for the flap. Why don't you use a 80 for both closure and the traction suture? Is it possible?
We can, sir. We can. In fact, a 10-0 nylon suture can also be used for closing the conjunctiva. The only issue is that with young children, you may not get them back for a removal, or in case of a loose suture, we don't, and especially with kids like these, when blebitis, endophthalmitis is such an issue, you don't want an added suture related infiltrate in them. But clearly an 80 vicryl can be used for both.
And what do you discuss with the anesthetist when you are doing the surgery? Do you give him any instructions?
Yes, sir. So initially when the EOA has to be done, we make sure that as soon as the anesthesia is being administered, the first thing we do is take the IOP with a Perkins tonometer. That is one thing that we are making sure. Rest of the examination is carried out after the anesthesia.
So once I start lifting the flap, I would ask him to hyperventilate. So it sort of reduces the vitreous turgescence and it becomes slightly hypotenuse. So you could plan that, and that's very helpful. And I also use a little bit of viscoelastic. Once you are passed into the anterior chamber with the first trabecular tome, you inject viscoelastics, chamber becomes deep, and then you could pass the right hand one again.
Right.
So that helps. And of course, as you showed, we are not used any side port for the, you do not show any side port. If you have used a side port, then its recommendation is that you suture it as well.
Sure.
Dr. Ankur?
Yeah, good points, Dr. Ganesh. I would just talk about the counseling part, which is most important for congenital glaucoma. At least in the private practice, we need to counsel the parents and they should be willing to understand the issues. I know that for the pediatric cataract also, there's a lot of counseling required. But here we are talking about multiple surgeries and issues related to glaucoma, which can be their long-standing treatment and all. And I use a little differently. I prefer to use the corneal, the superior rectus traction suture, so rather than the corneal traction. And I prefer to use a cotton over there. And also, I don't put a viscoelastic. I'll put air rather, and then make a side port with a 23 or a 30 gauge, 26 or a 30 gauge needle rather than that. So that's a little different we have. And I also use mannitol apart from the good deep anesthesia and hyperventilation to lower down the pressures. But it's a nice surgery, Dr. Sahebaan, nicely demonstrated. And we really find sometimes difficult to cannulate the Schlemm's canal, especially when the globe is 13.5 or 14 millimeters or larger, because then the distortion is a little too high to actually locate the Schlemm's canal. So rather than pushing the Harm's trabeculotome in the wrong direction and creating false passages, it is better to give up if you're not able to find out the Schlemm's canal in such cases.
Yeah, and then go ahead with your trabecular.
Yeah, go ahead. Yeah, and I tend to use 0.4 milligrams of mitomycin C rather than 0.2 because the fibrosis is a little too high in these patients and we don't want to kind of operate again and again these patients. A little bit of difference here. But
Dr.
yes.
Yeah. What would you do if you happen to perforate the cornea while passing the traction suture? Any tips on that?